story that I was told was that the planning committee, in discussing the topics for today, thought that you'll probably hear lots about surgery and medical treatment of gynecological cancer, but you may not hear a lot about the psychological care, and that the planning committee told me that that may be one area where gyne-oncologists might want to focus to up their game a little bit. So I've been asked to share with you some ideas about how gyne-oncologists can improve the care of women with gynecological cancer. Now you'll see from the title that I'm going to focus specifically on ovarian cancer. The reason for that is that I've been given 30 minutes as opposed to 3 hours, so I thought I'd better focus in a little bit. And the reason that I've chosen ovarian cancer as opposed to one of the others is that, at least in my practice, I red flag women with ovarian cancer for all the reasons that you folks know, that these women almost always have advanced disease when they're diagnosed. They undergo the huge surgeries that you folks perform. One of my patients refers to it as clear cutting. And then undergo fairly intensive chemotherapy only to be left with a very uncertain future. So these women are at high risk of experiencing psychological difficulties, and that's one of the reasons that I focus a lot of my practice on that patient group. So I don't have any disclosures. You'll see that there are 3 learning objectives for today. The first is, essentially to affirm that the best care of women with ovarian cancer tends to both their physical needs and emotional needs. Don't think I really need to belabor that point. Hopefully we're long beyond those days of the ovary in bed 4 and the uterus in bed 3, that we well appreciate that attached to those body parts, or where they used to be, are people who have feelings and thoughts and reactions about what's happening to them, and that if we neglect either the physical or the emotional, then the patient suffers. So the second learning objective, the one that I'll focus the most on, is to increase appreciation or understanding of what some of the unique emotional needs of women with ovarian cancer are. And thirdly, to make sure that you're aware of some of the resources that may be helpful to you in your practice, and resources that you can pass on to the women that you're dealing with. So my sources of data, I could have gone to the literature, and I'll refer to the literature a little bit, but when I received this invitation, what I thought I would do is to poll women that I have contact with, and essentially ask them, what do you think I should say? In what way does your gyne-oncologist help you from an emotional or psychological point of view, and what way might they do a better job in that regard? So they sent me pictures of their various gatherings so that I can give appropriate credit to the sources of my data. So I sprinkled some questions through my talk just to make sure that people were awake. So the first question is, when do patients have the greatest need for emotional support? Is it at the time of their diagnosis, during their first-line chemotherapy, after chemotherapy, at the time of recurrence, or transition from active treatment to palliative care? So are people able to vote? Is that working? How do I activate it?
Audio and visual. Are you able to activate the polling?
Shall I just move on? Okay.
What was the answer?
The answer is that the greatest need for emotional care is actually when women have finished their first-line chemotherapy and are moving into what are sometimes referred to now as the survivorship phase. Each of those time points are transition time points, and from a psychosocial oncology point of view, those are the times that women are most needing emotional support. But what distinguishes this time frame is that it often comes as a surprise to patients and to their families and sometimes to their caregivers. Some of the quotes there are that when patients finish their chemotherapy, they think that this should be a time to celebrate. They're told to go out and to live their life. But unfortunately, they still have lingering physical side effects. And then when those physical side effects tend to wane, there are still the emotional issues. And patients are often very surprised. They'll come to me and say, well, this is a time when I'm really struggling emotionally. I thought this should be a time when I'm feeling really good. What's wrong with me? And so one of the things that the women suggested that I let you know about is that one thing that you can do is just to warn them that when they're finished their primary chemotherapy, this may be a time when they really are struggling. And to help them understand that a little bit, that when they're going through their chemotherapy, they've kind of got their heads down, they've got a job to do, they have good support from family and friends because it's well recognized that that's a difficult time, that they're seeing all of their healthcare providers. But then when they're done, they often feel like they're kind of set adrift, they're abandoned, family and friends kind of go back to their own life. And that's one of the reasons that this is a difficult time for them. Another thing that often happens for women at this time is that they are essentially discharged back to their family practitioner. And that for many of these women, they have lost faith in their general practitioner, and for some of them, for the entire medical system. And of course, that's because many of them had a hard time getting a diagnosis. A woman that I'm quoting here said that she'd been doctoring for about a year. She'd been misdiagnosed a number of times, but what really troubled her was that she was dismissed and often told that there was really nothing wrong with her. And so for her to be kind of cut off from contact with the cancer center is, again, a difficult thing for her during that time. One of the books that I often recommend to patients is this book, Picking Up the Pieces, and they suggested that I make sure that everybody knows about this book. It's actually a Canadian book. Sherry McGee wrote it after doing some research about this particular phase in patients' journey. One of the things that I found helpful in my conversations with patients is this breakdown of the various wants that they have. And it may be helpful to you when you're listening to those questions that patients come to you with, to be listening, are these idealistic wants? Are they achievable wants? And are they ultimate wants? So let's look at each one of those one at a time. So the idealistic wants are probably pretty obvious, that they want a guarantee that the cancer is gone and that it'll never come back. They want reassurances that they're doing everything possible to keep the cancer away. They're often looking for some guidance in that because they're bombarded with suggestions from really everywhere about all the things that they should be doing to reduce the chances of recurrence. So they want to know from you, are they doing everything that's possible? They don't want to overlook something. And they want definitive timelines for things such as, when am I going to feel normal again? So idealistic wants, I guess listening for those and helping patients recognize that they're idealistic, but they really may not be achievable. And so to be thinking about what are the achievable wants in terms of providing some guidelines, validation about the difficulty of this time, and providing support. So I don't know whether this question you'll be able to poll on it or not, but here's a 55-year-old woman who was treated for stage 3 ovarian cancer. You're seeing her at her 3-month checkup. She's still feeling fatigued, has some chemo brain, some peripheral neuropathy. She wants to know when she can go back to work. Her husband's saying, well, your hair's coming back, you're looking pretty good, I think you should go back to work, we need to get back to normal life around here. She's been running into colleagues, some physicians that she worked with. She's a nurse administrator. They're asking her to come back. The place is falling apart. So what do you tell her? When can she go back to work? Do you tell her now? Wait another 3 months? In 6 months? In a year? Or, it's really too hard to say. Too hard to say. Well, I would suggest to you that that's probably the most unhelpful thing to tell the woman. I think I would suggest that you do try to give her some kind of a guideline. Each probably has their own practice. Actually, in this case, the gyne-oncologist suggested that the woman wait a full year. Some people might say, well, no, just kind of like the husband, she needs to get back to her life. I think the rationale given to the suggestion that this woman wait a year is to take the pressure off. Often, when there is that pressure, it makes patients more anxious and actually interferes with their ability to start to recover. And when she was told that she would be supported in having a year off, it actually freed her up to really start to engage in some recovery activities. She started to exercise, she went to a chemo brain class, and really started to invest in the recovery process. And I think the other strategy was that telling patients 3 months or 6 months, and if they're not ready to go back, then they're going to feel like they're a failure. If you tell them a year and they are ready to go back in 3 or 6 months, then they feel like kind of they're ahead of the curve. And then there are the ultimate wants that I think you would agree that our patients are wanting: the ability to face mortality without fear, to have a sense of inner peace, and to integrate their old with their new selves. Now, sometimes patients think that to not be living in fear, to have a sense of peace after they've had this diagnosis, they sometimes think that that is an idealistic want, that it's really not achievable. But it is, and I'm sure that you know many patients who have been successful in this kind of recovery. One of the things that I think that you can do and that the women wanted me to talk to you about is this, what we sometimes refer to as this tyranny of positive thinking. If you watch Oprah, you probably know about the secret, right? Where there's this pop psychology idea that if you believe in something 100%, then you're going to increase the chances of that happening. And if you even for a moment let sneak into your mind the possibility of an unwanted outcome, you're going to actually increase the possibility of that. Women will say that, if they bring up the idea that they're worried about a recurrence or an early death, that people will say, well, don't think like that. You can't think like that. And that actually is not all that helpful. One of the ways that I have of helping patients think through that is sometimes I'll bring down the DSM off of my shelf and have them read the definition of suppression. Intentionally avoiding thinking about disturbing problems, desires, feelings, or what the positive thinking people would ultimately want people to do is essentially repression, right? Being unable to recall or cognitively be aware of disturbing wishes, feelings, thoughts, or expressions. I think what people strive for, and it's perhaps a little healthier, is something that we might call restraint, which is the ability to temporarily set aside emotions during inconvenient times. In my mind, emotions are kind of like children. that if they keep pestering you and pestering you and pestering you, and you don't pay attention, they'll continue to pester you. But if you do take some time and spend time with them, then they can go off and play. And so the more people try to push feelings away, and this has been known for some time, citing my authority here, Carl Jung, that what we resist actually persists. And so helping patients think that through, and helping them understand how unrealistic it is not to have these concerns about a recurrence or an early death. Our patients today, right, they're very well informed. You can say that the internet is either a blessing or a curse, but they do go to websites, they see these graphs that you're all familiar with, they read the things that, you know, the gynae oncologists have written at very reputable web pages, the NCI web page, and so they know if they've got widespread disease that they read that the mortality of ovarian cancer is 65% of the incidence. 5-year survival for suboptimally debulked stage 3 and 4 is 10%, and so on. So these are pretty stark statistics. Now you can argue whether they're out of date and perhaps help the woman understand exactly what her prognosis is. But that idealistic want, that 100% reassurance that she's going to be one of the lucky ones, of course, that's something that can't be given. So supportive expressive group psychotherapy was a therapy that was developed in the late 70s, early 80s. It's a therapy that actually supports patients in confronting death and dying, and it's been shown through 3 randomized controlled trials now to actually improve psychological well-being. When these groups were originally started back in the 70s and 80s, they were quite controversial, and some would say that they're still controversial. What are you going to be doing, putting these women together in a room? They're just going to watch one another have recurrences, their disease advance, they're going to watch one another die. How can that be helpful? Well, as I say, I'm not going to go through what the process of the psychotherapy is, but we've got pretty good evidence that these groups work. Like anything, they're not for everybody, but they can be very effective. And to quote one of the women who participated in our group, actually wrote a book of poetry based on her experience of being in the group. She said that she had learned from them, she's referring to the other women, that whatever comes can be lived eyes wide open, that you don't have to live with fear. So another question is, what is the stress level of spouses relative to patients? Yep. Let's see what you said. Good. So if we measure the level of distress of patients and that of their partners, it's usually about the same, but if it's different, it is actually higher. So it doesn't look like I need to belabor that point, but one of the things that the women that I talk to, again, ask me to pass on to you, is that you can be very helpful in encouraging their spouses to access support, to legitimize that they are experiencing a high level of support. Most of the spouses happen to be men, right? And we know that men often aren't very good about recognizing their own feelings, reaching out for help. They often feel like, they need to be the rock of the family, and if they take time to care for themselves, well, that's taking time away from caring for the patient. And so you can be very instrumental in terms of encouraging those spouses to accept the help that's offered to them and to seek it out themselves. So in particular, they want me to remind you that you have tools beyond chemotherapy and surgery to help in the recovery, that your relationship is important, that unfortunately time with fellows is not a good substitute for time with the primary gynae oncologist, that it's that time that helps give the woman a reassurance that they matter, that they're being looked after. Again, remember back that many of these women do struggle with having faith in the medical system. In many cases, they've extended their faith and trust to you. And so spending that time, knowing that you are doing everything possible to make sure that they don't have a recurrence, is something that gives them peace of mind. Hiring good nurses, of course, that's a key to this, that the nurses play a huge role in helping them understand the information that's been provided. And one of the things that the nurses say that's really helpful is having kind of that go-to touchstone nurse that follows them over the course of their treatment. Again, somebody who's looking out for them. They recognize that for many surgeons, dealing with emotional things may be outside of a person's level of comfort, but make sure that you do refer them on to the resources. Ovarian Cancer Canada has some good resources. Their booklet, By Your Side, Still By Your Side, many webinars that you have participated in. Cancer Chat Canada, these are professionally led online groups, so they're available to people essentially regardless of where they live. Ovarian Cancer Canada supports one specifically for women with ovarian cancer. Canadian Cancer Society will hook women up so that they do have a buddy, and that can be done electronically. And a reminder of the book that I mentioned. So essentially, the thing that you can do is to validate that this time after finishing primary chemotherapy is often a time of great emotional struggle. Normalizing that, letting women know that this is a normal and expected part of their journey is helpful. A reminder of the importance of your relationship in terms of their emotional healing. Refer them to the resources that are available, and don't forget about their spouses. Thank you.
That was terrific. Thank you, Dr. Robinson. If I can have you stay to take some questions. Do we have questions from the audience? Yeah. Alexandra?
Thank you very much. I enjoyed a lot your talk when you were talking about when to go back to work. And my question is, how do we draw the line between needing some more time to recover and fearing going back to work, you know, because at some point going back to work may just become so big and so stressful that if you don't go back at some point, you'll never face your fear and not ever be able to go back to work.
So there have been some good back to work programs that at least we have available in Calgary. And essentially what they do is to help people assess whether or not they're ready to go back to work. For example, with ChemoBrain, to actually undergo some testing to find out the degree to which cognitively they're going to be able to do the tasks that are demanded of them. One of the cognitive changes that you probably all know is multitasking. And depending upon what the job is, if it's a job that does require a lot of multitasking, then women are going to need more time. If they don't have to multitask in their job, they may be able to go back to work a little bit sooner. The physical demands as well. One of the strategies that's suggested for women to test themselves as to whether they're ready to go back to work is to actually get up at the time when they would normally get up. Commute to work. See how that is. Spend the day being up and about. And some of the women will find that just that process of getting up and getting themselves together and fighting the traffic to go to work, they're done for the day. And others will find out, well, I guess I can do it. So this idea of testing things out is a way of starting to help them really assess, you know, is it an unwanted fear, or is there a base to which they're saying that no, I'm not ready to go back to work?
Hi, Jake McGee from London. We're lucky in London. We had Well, we had a spiritual care counselor. She was working on her PhD, and we sent a lot of patients to her, and subjectively the response was great from the patients that I had involved with her. She does qualitative research. She was kind of resistant to the notion of quantitatively looking at the benefit that patients might derive from involvement in her care. And I was at the IGCS, and the Dutch group presented a study, a randomized controlled trial looking at survivorship care plans, which are recommended by the Institute of Medicine. And what they found is that patients who were actually put on a formalized survivorship care plan had less belief that the treatment they were receiving would actually work, and had overall lower quality of life scores. So I'm just wondering, what do you think the role is of sort of trying to more rigorously or scientifically look at things like involvement in a support group is, and should we be doing that?
Well, with respect to support groups, I mean, like any treatment, you know, it has to be chosen for the right patient, and these support groups can become toxic. So you have to, you know, there's been actually a lot of research going into really understanding what the mechanisms are, and I'm not exactly familiar with, you know, that particular study. I mean, these survivorship care plans, you know, giving the discharge letters, I know there's some real question as to whether they do make a difference. One of the, I think, the best things that women can do in terms of the recovery is to get into a regular exercise program that's tailor-made for them in terms of where they are at physically, takes into consideration sometimes the peripheral neuropathy that they have.
We'll take a last question from Walter.
Thank you. So one of the buzzwords now is post-traumatic stress syndrome. And how closely is recovery from cancer patients to post-traumatic stress syndrome? How are there any corollaries, or?
There have been some studies that have looked at it, and I mean, to qualify for a diagnosis of post-traumatic stress syndrome, of course, there's certain symptoms that one has to have in order to, you know, really qualify for that diagnosis. The vast majority of cancer patients don't meet that criteria. It's not to say that they're not traumatized by what they've gone through, but where that has relevance is in terms of the treatment, and there have been some suggestions that we should be using more treatments that parallel post-traumatic stress syndrome, and I think it's a little bit too early to say, but often people would suggest that is not appropriate because they're really not having, you know, what is typically defined as post-traumatic stress syndrome.
Sure, okay. Sure, last one.
Thanks very much, Dr. Robinson. I really enjoyed your talk. I wanted to ask you about the evidence for the returning to work recommendation at 1 year, and the reason is, you know, it's a problem that we all struggle with, and that most of our patients are asking for our recommendations. And I have to admit, I've never told a patient a year, and so I was feeling quite guilty when I heard what you said, and I have to admit that what I've done personally is really tried to, with a lack of evidence, tried to individualize my approach to the recommendation that I make to each and every patient, and try to explore not only how they're feeling physically, but you know, to explore some of the other issues with regards to what's going on at home, what their family situation is, what their financial situation is, in terms of trying to explore some of the issues with regards to, you know, what's going to be the impact of waiting to return to work, and what sort of job they have. And so I'm hoping that you'll be able to comment on some of the evidence for the year recommendation, and just to help provide some guidance with that.
So I'm not suggesting that year should be the gold standard. And I sure wouldn't suggest that what you recommend is that women just kind of sit around and twiddle their thumbs waiting for that year to pass, but of actually helping them, as I say, in terms of a return to work program, of having them think about, well, what's the process of recovery? What's my responsibility? What are the things that I can do to help with my recovery, and to deal with some of the lingering side effects, and to deal with some of the emotional issues? So it's to be thinking of it as a time to recover, and that there are some clear things that people can do to facilitate their recovery. Now, I know patients who actually work through their chemotherapy, much to my surprise, and actually that seems to be really helpful for them. You know, question that sometimes I ask is, you know, is work something that gives you energy or takes energy away? And for some people, their work actually energizes them, and so going back to work, you know, may be very therapeutic for them. So yeah, I think you have to individualize it and take into consideration what the nature of their work is and how profound their side effects are, and to test out. You know, you can do that in some real ways to find out to what degree are the issues significant.
Terrific. Thank you, Dr. Robinson.